way to stand out on your personal statement, just by being you. Honestly, you want to be consistent from your applications to your personal statements to the time you interview. That's what's really going to help you get in, being consistent. So whoever they read about in the personal statement is who they want to see at the interview, right? Hi guys. Hi, happy new year. Welcome to ep57. Hello everybody. Excuse me, happy new year. And welcome to ep57. It's a new year, new week. Hi everyone. As you all know, I'm Rhodeline. I'm the host of ep57. Excuse me for today. I am sick, a little under the weather, so excuse me if I cough a lot or yeah. So we're gonna hop right into it. If you are new to ep57, I'm Rhodeline. I host ep57, and sometimes I also present. If we don't have a presenter, a guest presenter like today, I'll be presenting something. I try to do a case study or something just that'll be helpful either way in your career and career specialty endeavors, whatever it is. And yeah, usually if I'm presenting, then I usually start with the Q&A, giving you guys the opportunity to ask me questions and answer them. And if I don't have the answer, as you all know, I try to get the answer to you guys. And then I have a case study. Well, I don't necessarily have a case study for you guys today. It's more of it's a PowerPoint. It's still a learning. You'll still learn. You'll still get credit. But it's just something a little different about the ER. But either way, it's still going to be fun. So I do emergency medicine. I am an ERPA, or I do emergency medicine and urgent care. So the majority of my presentations, at least when I present, will be ER, urgent care. We do have a guest for the remainder of January. I think next week is, I forgot, internal medicine. I think we're going to have somebody in oncology too. I think the only specialties we haven't really done are ICU, like critical care, and oncology. We haven't really done endocrine, and I think that's about it. I think we covered just about everything. If you want to look at past videos, you can go on our YouTube page. Access to our YouTube page is on my Instagram page. I don't know the exact text to put in for YouTube or search. I don't remember that. But if you're still new, you want to like watch new stuff, you can either go on YouTube, but of course I'll have like repeat of of old specialties, so you don't have to worry. Alrighty guys. So it's always going to be emergency medicine or urgent care when I present, at least, because that's my forte. All right, Q&A. We already got some questions coming on. How can I find a PA to shadow? I've tried multiple times, but never leads to an opportunity. I know that's very difficult, especially around this time, and especially with things, getting more heightened with COVID and everything. I am, as you all know, creating a platform that will help facilitate that and help you guys find PAs to shadow with MedSembly. But in the meantime, I always recommend going on Facebook groups, various Facebook groups. There is the Physician Assistants of Color Facebook group. They're also known as the PAC. They have pretty responsive PAs on there. I'm putting the names here. Their group. I also Physician Associate. There's an actual Facebook group called Physician Assistant / Associate. There's like a few Facebook groups. If you post to there, you can find somebody. And if you also on LinkedIn, sometimes they're not as responsive, but I have a little strategy for finding people on LinkedIn. Of course, you want to kind of message as many people as possible. And then you want to message them, but first you want to connect with them. You want to send like a nice inviting message. You don't want to right away ask them for a shadowing opportunity. You first want to introduce yourself and let them know you're interested in the PA field and see that they're a PA and would love to follow them to learn more about the specialty. And then as time goes on, after a week or two of following them, then you can kind of, and liking their posts, whatever they do, you can send them a message and share more about your your interest in being a PA and how you would love to shadow them to learn more about the career, you can do that. So I say LinkedIn, Facebook groups. You can actually walk to the offices, like to go to the various clinics. You can also call hospitals, just call around, call as many places as you can. That's what I had to do. Call doctors' offices, call hospitals. But hospitals, it's not like right, you can't directly speak to someone. It's usually like volunteer services or whatever it is. I know at like hospitals in New York, it's like volunteer services. And thank you guys. Thank you. Volunteer services at the hospitals. And yeah, I hope that's helpful. I'm still working on creating a template for reaching out to PAs for shadowing opportunities. How far in advance should I ask for a letter of recommendation for the upcoming cycle? So you want to ask when the cycle opens, basically. Well, you can let them know that you want to, you plan to ask for a letter of recommendation, or if they'd be able to write you a letter of recommendation. But that should be after consistently communicating with them, keeping an open line of communication, updating them on your journey, not making it seem like you just kind of using them. I mean, I'm not gonna lie. I've had some students, you know, build a relationship with me, and then I wrote a letter of recommendation, and then they got into PA school, and then I kind of don't hear from them anymore. That's fine. We all use each other to a certain extent. But before that, like, try to, if you shadowed a PA or worked with somebody, and you no longer work with them, and you're looking for a recommendation in the future, try to keep that communication open. Try to, you don't have to message them, text them, call them every single day, but periodically, see how they're doing, send them a message, update them about your journey, let them know how life is going on, what's going on with you, any hurdles you're facing, really foster that relationship with them. Don't just wait until the time comes to apply to say, oh, I need a letter of recommendation. And if you plan to apply, or if you plan to submit your application in May, then I would at least wait a month to let them know, and give them a month or two to apply. So you don't have to. So I don't honestly remember how it works with CASPA, because things have changed since I applied. I don't think that you I think that you can send your letters of recommendation, don't quote me, before you submit. It's either before or after you submit your application, but I think you can change them. You can change who you want and add or remove people. But either way, you want to give them ample time to write it, to get back to you. I would say at least a month before you want to actually submit it. So you reach out to them a month before. Give them time. I think that's how it works. I think you have to send your letters of recommendation, or they receive it before you submit your application, or else it's kind of deemed incomplete. I think that's it. But don't worry, I have people that know CASPA a lot better than me. How should we keep track of shadowing hours? So it'll be on your application. You'll be able to input that on CASPA, and then your schools might ask for verification. They might have you fill out a verification form, and then you'll send it to me to do more paperwork. But you just fill it all on CASPA, and if your school needs extra verification, they'll send you a document for that, and I fill it out, or you reach out to me to fill it out. That's it. All right. Let's see. Hope I'm answering your questions. How should you track hours? Just write them in a Word doc, Excel, whatever's easy for you. I actually have some Excel sheets, I believe, to track your hours. I have a lot of resources on hand. If you guys want the resources, let me know. Sorry. Try not to cough. How many hours of patient care experience, healthcare experience, shadow experience, and I actually have this also as a resource. So there's no, especially for patient care experience, they typically like 1,000 to 2,000 hours. It really varies by school. See what your school likes, but the average I've seen is around 1,000 to 2,000 hours. Some schools are more strict than others. Some schools are okay with 500. Some schools want like 2,500. So see what your school wants. A good amount to have, I say, is at least 2,000. If you have on the lower end, it doesn't mean you won't get in. So don't, go crazy. Just, I say to have at least 2,000. If you have like 1,000 or so, that's still okay, because at least by the time you start school, you have, that 2,000. So 2,000 hours equals 1 year of full-time work, like working 40 hours a week, 5 days a week. So if you do 40 hours a week times 4 weeks, times 52 weeks in a month, in a year, then that should equal about 2,000 hours. But of course, you guys won't be able to work the full-time hours as students, so that's okay. So by the time you graduate, if you start working like your sophomore or freshman year, even junior year, you should probably be close to 1,000 hours by the time you graduate, and you may need to take a gap year to finish your hours out. But I recommend at least 2,000 hours as far as patient care hours. Shadowing hours, I say at least 50 hours. Some people have way more than that, but I say to have at least 50 just starting. Volunteer, about the same. Some people have way more, but I say a good amount is just at least 50 hours. Competitive, if you want to be competitive, some schools, like I said, some students have hundreds of volunteer hours, hundreds of shadowing hours, hundreds of thousands of healthcare experience. But I think it's just like a case by case basis. I would go with what, of course, look at the minimum to have and try to go beyond that. And then rather than focus like so much on, conquering every little thing. Of course you want to conquer every little thing, but if you're really great, like excel, like amazing at one thing, it'll also be good to highlight that on your application and stand out. So what I mean by that is, rather than trying to be perfect and get hundreds and hundreds and hundreds and hundreds of hours in this, it's okay to get, 100 hours in shadowing, and then be so devoted to volunteer. And you can talk about your devotion to volunteering. You know what I mean? What I'm saying? So don't try to, burn yourself out trying to get, all these crazy hours in such a small time when you can get what you need, but put energy into what you really love doing and what really shows who you are. Okay, guys. What do you think are the best patient care jobs? Um, me, I don't really do, like, as far as stuff for PA school, because it's like really just doing a requirement. I don't necessarily see what's the best. I kind of focus on what's the easiest to do and get done and get where you need to go. I don't know. So, because you want to be a PA, they're all going to get you to where you need to be, right? Whether you do MA, medical assistant, CNA, whatever it is, you're going to learn. It's your job to make sure you get the right job to where you'll learn, because they're all great, in my opinion. You'll get that experience as long as you're in a good job, like a good place hires you. So I would say do what's going to get you there, the most feasible route. So if you don't have a nursing background, or if you're just finding out about PA school and you don't have much time, you wouldn't really want to do LPN, because LPN is going to take like a year, and then you have to find work and whatever it is. So it's going to take you anywhere from 2 to 3 years, or sometimes more than that, just to be a PA. So the best thing is probably to do CNA or MA. So those are my two favorite, like CNA and MA. I really like medical assistants, because you get so much experience. You do so much hands-on stuff, drawing blood. You can sometimes start, well, at least in our urgent care, you do the notes, a lot of our notes for us, or at least start the notes for us. You really get a lot of good experience with CNA. And it's not just, with MA, it's not just kind of like, doing basic, rudimentary stuff. You really get that hands-on with medical assistant, and you get to be a medical assistant in a short time. So that's one of my favorites. MA, CNA, EMT. I'm so sorry. I'm like, my head. EMT, those are all great. Techs are very similar to medical assistants, at least working. It's just like, to me, it's really working in the ER or working in the hospital versus working in the doctor's office. You guys really like to know what I think. I see a lot of questions about, what do you think? I don't be knowing what I think. My head's not. My thinking sometimes is a little unconventional. Will schools be more forgiving with patient care hours given the pandemic? I definitely think so. I think they have been. I think as long as you find some way to get them, whether it be virtual, of course, I think they've been forgiving and more lenient with getting them. Do any programs allow students to work part-time while in school? Okay, technically, at least from my experience, programs don't really know if you're working. It's not like they track you or they have a device to say, oh, you're working, you're not supposed to be working, you know? So I don't think that's the case. They don't recommend it, they don't advise it, but if you want to work, that's you that want to work. That's your grades that's going to be affected, right? Of course, if they notice, some academic issues, then they'll discuss it with you or they'll try to get to the bottom of it. And that's what they should do. But they don't allow it. But you're your own person, you're an adult, you're a consenting adult, so you do whatever you want to do as long as you're aware of the consequences of that. So programs don't advise it, they strongly don't, and I don't either. If you really, really need the money and want to do something, then I say, of course, on the side, like on the weekends, or something that's very flexible, something maybe virtual even, where it won't require much time. But of course I don't advise it because PA school is so draining and takes up a lot of your time. Okay, I hope I'm answering the questions in order because I don't want to miss other questions. I'm just receiving so many. I always get this question, what is the best way to stand out on your personal statement? Just by being you, honestly. You want to be consistent from your application to your personal statement to the time you interview. That's what's really going to help you get in, being consistent. So whoever they read about in the personal statement is who they want to see at the interview, right? So I think that's a big thing. Be consistent, really show who you are in the personal statement. Don't talk about stats. Don't tell me what's in your resume, whatever I can find in your resume. I don't really want to see that. Of course, you kind of want to tell us about your experience, but what I mean is don't list everything. Oh, in 1999, I joined this. In 2010, I did this. You know what I mean by that? Really tell a story. Be a great storyteller. Do a good job at, telling us your story, who you are. Think about how you would write an autobiography about yourself, but it's not really an autobiography. So just do a great job at telling your story. And as far as, I think that's really how you're going to stand out, because your story is different from everyone else's, right? My story is different from your story, So don't focus so much on stats. Don't focus so much on, you want to flex, of course, but don't focus so much on the numbers and, don't sound basic. I always say that. By basic, I mean use great detail, be elaborate. Let's see. In school they taught you show, not tell. So really show us, be very elaborate, really tell us, paint a picture, use anecdotes, give examples of patient encounters. Yeah, really, I like to feel like I'm reading a book or reading something where I don't want it to end or where I don't want to put it down. So just really get good at telling your story. If you did something amazing, tell us about that. If you founded something, if you went on, an amazing trip, if you did something great, even if it's not healthcare related, just tell us. And it's good to always relay it back to healthcare. So even if it's not healthcare related, how has it made you a better individual to in turn prepare you for PA school and make you someone that'll be a great PA student? How current do these hours of patient care need to be? I think 3 years ago is fine. 3 years, if you have patient care hours in healthcare, I think it's fine. Of course they want, excuse me. Of course they want more recent stuff. So if you try to, of course, get that recent experience, but if you combine it with past experience, I think you should be fine. Make sure you just have a good amount of past experience. Okay, we did that. Do any programs allow students to work part-time while in school? We went over that already. Do you recommend shadowing other medical providers? Yeah, you can shadow a doctor. You cannot shadow an NP. It won't count as shadowing hours as far as I know. You can get a letter of recommendation from an NP if you work closely with one, but I don't recommend you shadow an NP. You can shadow doctors. You can shadow PAs. Should you put off applying for another? No, heck no. Somebody asked, should you put off applying for another cycle if your shadowing experience has been virtual, if all your shadowing experience? No. So you got to turn your lemons into lemonade. You have to do a really good job at explaining how, of course you're going to tell why you were only able to do virtual shadowing, but really explain what you learned from virtual shadowing, the value of virtual shadowing, what you were able to get from virtual shadowing that you might have not gotten from in-person shadowing, like being able to see an array, whatever that word is, like being able to see, a variety of specialties, and connecting with different PAs or learning from different PAs in various specialties. So don't put off because of shadowing. Don't. Virtual shadowing, to me, in my opinion, is just as good. The only thing you're not really seeing is patients in person. But hopefully the case studies have been interactive enough to where you really feel like, you're understanding what's going on, and you can paint that. We've painted a good picture of that patient experience, and where you can see how it's like getting a history, doing a physical, and all that. Do you think it comes across as arrogant if you mention your research or studies you did in school in your personal statement? No. Just make sure you're able to relay it back to, why it makes you a great candidate, your strengths, how it will prepare you for PA school. If you guys have more personal questions, just message me. Is there a bonus for certifications like a medical assistant with a national certification? I believe you have to be certified in order to work. Many places want you to have that CCMA. Can you talk about your specialty a bit, pros, cons? How long does it take to get certified for MA, CNA in that sense? It varies. I'm not sure exactly how long the programs are. I think like some of them are generally 3 months long, but it varies. Can you talk about your specialty a bit, pros, cons? I'll talk about that in a little bit, more about the ER in a little bit. But just as far as pros, cons, I work in the ER, or most of my special time has been in the ER. I'll probably go back to the ER again, actually, in probably in a few weeks. I may go back to New York, guys. uh, so I've worked in the emergency room. Pro has been really the learning experience. That's really like why I like the ER so much, because you see so much and you really get a chance to learn so much. You never stop learning, and it's never a dull moment. You'll see so much of everything. You can see a variety of different cases in a day. You'll see cardiac, pulmonary, abdominal complaints, like I said, chest complaints, back pains, headaches. So you see a little bit of everything from every body system. So you just never stop learning. You just never stop. You're always going to retain and know that information. It really helps for board exams and even future specialties that you want to get into. So that's really why I liked it. It's the only specialty besides like urgent care, maybe family medicine, internal medicine, where you are, where you have so much experience and are exposed to so much. Another reason why I like ER versus internal medicine or family medicine, just in case you have the same personality as I do, is that, I like to be one and done. I don't like to see the same patients over and over and over again. I'm not really into building relationships like that with patients. So I couldn't do family medicine. I couldn't see Aunt Bertha 1 month and then see her another 3 months. And I don't really care. I like to just treat them, send them about their way. Hopefully they don't come to the ER. A lot of times patients will be frequent flyers in the ER, and I'm fine with that. But I just don't like treating chronic illnesses. I just can't. So that's why it just kind of fits my personality. And I'm really, bubbly, and I like excitement. I'm adventurous. I'm like an adrenaline junkie. So cons of the ER is that the staffing issues. Especially if you work night shift, there might be a big staffing issue. Sometimes support in the ER. You work with a ton of different physicians, supervising physicians. Let's see. another con. It gets really, 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 really busy. And when it gets real, if any of you are like me, when it gets really busy, I kind of turn into scatterbrain. I'm so sorry. Like, I get like so like overwhelmed, and I'm like, okay, what am I doing now? What am I doing now? What am I doing now? Like, I kind of still remember things, but it just like it's easier to make mistakes. And like for anybody, it's easy to make mistakes when you're just overwhelmed and you're extremely busy. Like sometimes I'll have like 9 patients waiting to be seen or something, or like 4 patients and I'm still on 5 patients or whatever it is. And that's a lot of times due to staffing and just not having a good structure in the ER. But yeah, I just don't like feeling super overwhelmed. I can actually take a lot of, the busyness, like to a certain extent. But when it gets to a point where I'm just kind of all over the place and I'm just like a scatterbrain, and it takes a lot for that to happen with me. Okay, let's see. Is there a bonus? Somebody asked, is a letter of recommendation required for a PA? No, it's not required, but it's recommended. I recommend 2 things. I recommend you at least have a letter of recommendation from a PA, and I recommend a PA read over your personal statement. Just because you're applying to PA school, right? So you want to have people that have experience, that know what's going on, either a PA or a PA student that know what's going on, be able to, or have that experience, be able to, yeah, it's 2,000 hours. I'm just kind of reading your comments. There's like a Q&A section and there's a chat box. So I'm trying to read if I missed anything. And I'll also put my social media if you guys don't have it. If you guys are new to the crew, I honestly don't post as much as I should on my personal page, or as much as I'm not really into. I guess I'm not really into social media and posting, but I mean, from our MedSembly page is where you'll find me. Not really my personal page. Are you a travel PA? I am sometimes when I want to be. But I guess you could say that's what I am. Yeah, I am. So I travel whenever I find a good opportunity. So I'm likely going to travel to New York soon for a COVID assignment again. So yeah, it seems like COVID is never going away. You mentioned good question, we should not be shadowing NPs, considering NPs and PAs have similar roles. Would this not be a good option? Do PA schools not count NP shadowing hours? Right. PA schools do not count NP shadowing hours. As far as what I know, I've never heard of a PA school counting that. And in the real world, yes, in the real world, PAs and NPs have similar roles. When you get out there, that's what it is, right? But in the school world, when you're actually in learning, they're different. So you don't want to, they have different styles of teaching, learning, their nursing model versus the medical model. And you kind of have to know that. If you want to do if you want to be a PA, they might ask you that in the interview. Why don't you want to be an NP? Or why don't you want to be a doctor? So you have to know the differences. So they don't want you to shadow an NP because typically that's one of the big differences, how we're taught. Nurses are taught in the nursing model. PAs are taught more like physicians. So that's why it's better for you to shadow a physician. But as I said, when you actually get out there and start working, it's really no difference. But for the sake of getting into your program, that's what you got to do. You got to do what you got to do. And it's better. I mean, if you want to shadow a PA, I mean, that's what you want to be. You want to be a PA, right? So. Somebody asked summer right before college. I honestly don't know if shadowing right before. I usually they count, kind of what you did during your undergrad years. Being that you were about to go into college, girl, you can just kind of say it as that. You don't have to. You can put some people start college in summer whatever year, right? So I think you should be okay. But if not, just make sure you have a good cushion to fall back on. I hope I'm answering all the questions. There's so many, so I'm only answering about 3 more questions, and I'm going to move on to the presentation. How was your journey to PA school? Or were you pre-med at one point? I was pre-med at one point, and then I realized I couldn't pass calculus. I was pre-med, and that wasn't really my decision. That was kind of my parents' decision, honestly. And when I, did a lot of soul searching, finding myself, trying to go over what I want to do. And I'm keeping this short because I kind of talk about this in almost every e-shadowing session, because I know you guys are new and always want to learn about me. But you can learn more about it in my other e-shadowing sessions. But yeah, I had to do a lot of soul searching to figure out what I wanted to do after I decided I couldn't do medical school or didn't really want to do medical school. And it wasn't really due to the classes. I could have taken pre-calc or calculus over, or I could have really honed down, found a tutor, a personal tutor, whatever it is I needed to do if I really wanted to be a physician, right? Nothing could have stopped me. But it was just, I didn't, finding myself, trying to figure out, I figured out, what I wanted to do with my life, who I want to be, the type of life I want to live. I just didn't want to go to school, be in school as long, for that period of time, for, 8+ years. And as I grew older and learned more about the PA profession, I found that it was aligned with who I am and what I wanted to be and do. That's a synopsis. Do you recommend to take GRE even applying to schools that don't require it? No. Like I said, I'm very simple. I just do what I got to do to get where I need to go. So if they don't require it, you don't need to take it, right? So if they don't require it, then I wouldn't take it. And if you're only applying to schools that don't require it, then don't take it. If you are going to apply to schools that require it, then take it. I don't think taking the GRE, if they don't ask for it, is going to like push you up. You can put your energy into other things. If you receive a low grade in a course, where would you recommend not bring it up unless it's mentioned in an interview? Okay, if you received a low grade in a course, it'll be on your application. So you have to put everything into CASPA, every single thing. Like even if you withdrew from a class, if you failed a class, whatever it is, you have to put it all into CASPA. If it's going to be on your transcript, then you got to put it into CASPA. As far as explaining it, I'm sure there's boxes on CASPA to explain like discrepancies and whatnot. And sometimes you can mention it in the essay. I say don't waste too much time explaining stuff like that in the essay, because you want to highlight your strengths. You want to show yourself off rather than talk about sad stuff like bad grades and stuff. You want to be positive and flex, not like deflex. Just kidding. I'm kind of corny, but yeah, so I say, if you want to talk about it a little bit somewhere in the application, there should be a box. You can, but I wouldn't spend so much time on it. If they bring it up in the interview, which they may, then be prepared to explain it. Be prepared to explain any and all discrepancies, actually. In my essay, you can find my essay actually on the MedSembly test app. In my essay, I did mention that I struggled in college and struggled with finding myself. You can say something like that if you want to in your essay, but I didn't say that, oh, I failed a class. I don't think I said, oh, I failed a class. I didn't fail a class, but I don't think I said, oh, I got a C or I withdrew from a class. I didn't really go into detail. I don't remember doing so. And if I did, it was like really short. I didn't spend much time on it. And I don't remember them asking me on the interview, but just be prepared for that. Okay, one last question. When reaching out to a PA, how should you address them in an email? You can say PA such and such or Mr. and Mrs. Honestly, just thinking about myself, I don't care what somebody calls me as long as my name is right on my check. Just kidding. But I know some people are kind of iffy and picky about stuff like that. So it's fine to say PA Chow, PA whatever, PA Joseph, PA Matterall, PA, Angela. But you could say Mr., Mrs. to me as well too. I don't see anything wrong with that. I know many courses have been moved to online. Would schools turn my application down? No, unless they say it on their website, as far as what schools recommend or approve of and don't approve of, unless they say it on their website, you should be fine. As far as taking online classes, community college classes, if it's not on their website that they don't accept it, then you should be fine. If you're not sure, or if you're still, on the fence or want to know for sure, just reach out to the school. As far as how to put them in CASPA, you'll see all of that when CASPA opens. Yes, you'll be able to put a description of it, which you can put what you learn, all of that. CASPA explains it. I'm gonna do like a CASPA seminar, guys. Just make sure you're following me on social media, preferably Instagram or our Instagram pages or Facebook, because I post all updates, all things going on social media. And there'll be a lot coming up. Okay, guys, I'm going to do the case now. Well, not the case, but the presentation now. So as far as emergency medicine, I'm an ERPA. If you've never had a case study or presentation in the ER from me, then get ready to be mind blown. Just kidding. Okay, so in the ER, for everybody that knows me or knows how I like things done, you're always going to be thinking about the words first in the ER with every patient that you see, even if it's a mild thing. If I might have a headache right now, guys. I'm sick right now. I guess, y'all, just to let you guys know, COVID got me. So that's what I'm struggling with right now, but I'm perfectly fine. So if I was to come into the ER right now, I'm completely stable. If I said I had a headache, even though I'm completely stable, you still want to make sure and cover yourself and make sure that my headache is not due to meningitis, or is not due to a bleed, or is not due to, anything else like that, right? Or if I say that, I have a cough, you want to make sure the cough is not a pneumonia, right? Or, you just, that's what I mean by words first. And it's not necessarily kind of jumping to test. It's never jumping to test. It's more so asking the right questions to see if what tests are needed, or if any tests are needed at all. And that's going to support your you overall as a whole. If something were to come up, if it was, your documentation, just so you guys know, I'll say a lot throughout the throughout the presentation about legal documentation, but there's a lot of cases where you may be called into court and it really is a legal document, but this is all your documentation is legal. It can always be used in court. It can always be used against you. Just always think of this as a legal document, and you have to document your best. You have to cover yourself. So that's what I mean by worst first. Always be thinking about what can kill your patient. Even if it's the simplest thing, make sure to document and rule it out. If you don't feel like the patient does not need a head CT, then write why. Write what the patient says, write the patient's complaint, write that the patient is stable, write that the patient has stable vital signs, write that it's not the worst headache, write that, the pain is a 5 out of 10, all of that, okay? Always do stuff to corroborate what you plan to do. Corroborate your SOAP note, or your plan of care for that patient. Okay? That's just a quick run through. I have other videos where I go into more detail. I haven't used this in a while. So with patients, you want to be thinking about stable versus unstable. I'm sorry. Thank you, guys. Thank you, Sarah. You want to be thinking about stable versus unstable. And their ESI level, basically, if they're a level 1 to 5, level 1 is basically dead or dead or cardiac arrest. Level 2, I've never really seen a level 2 cardiac arrest unless they become one, unless they kind of came unstable but not in arrest, and then they became one. Usually level 1s are either coming dead on arrival, or dead, or whatever, or bad trauma, or cardiac arrest. Level 2 is kind of near that. Level 2 is just really bad. They'll need a lot of resources. They do the ESI level based on the resources that the patient will need in the ER, based on the patient's presentation, the patient's vitals. So it's a lot of things that go into it. So the ER triage nurse sees the patient, does vitals, asks them questions, assign them a level. Like I said, level 1's the worst. Level 5 is like kind of easy in and out stuff. 4 and 5 are easy in and out stuff that can be treated in urgent care typically. They get a bed assignment, like basically placed somewhere in the ER, and then a PA, an NP, or a doc evaluates the patient, picks up the patient. All right, so rather than do a case study, I was going to do a case study on COVID, but we can do that next time. But rather than do a case study, I want to discuss tough cases in the ER and what to do. Just if you run into issues in the ER, which you will always run into issues in the ER, especially if it's like sensitive stuff that will become a legal issue, or will likely become a legal issue. A lot of these will become legal issues. Just so you know what to do, and the proper steps to take to ensure the patient's safety and your license. Remember, you guys work very, very hard for your license. It's going to cost you like $100,000+, right? PA school, getting your license, doing all this stuff, paying for this, paying for that. It's going to cost you about $100,000, right, for this. So you want to protect it. Not only that, but because we all have hearts. We don't want to ever harm somebody. We take the Hippocratic oath. You don't want to ever do any harm, even if it's like not your fault, even if you didn't mean to. We still like want to be able to sleep at night. So yeah, make sure you do the best you can. Make sure you look out for the patient and look out for yourself and your license. So that's why I want to talk about these. These are some just important things to remember that may, get you in some drama and, how to go about them. All right, so it's domestic violence, child abuse, DNR, psychiatric holds, conflict with the supervising physician, attending, or hospitalist, and any uncertainty, anything really. Okay, domestic violence / sexual abuse, assault. I actually have seen more, and just a disclosure. Nothing I say is like the end all be all. Every hospital is different. I like to talk from my experience, working with the patients that I've worked with, my experience with how we've done it with my supervising physician, how we do it at the hospitals I've worked at. So every hospital is different. Just because I say something, it doesn't mean that it's going to be true for everywhere. So don't come into me and say, Rhodeline, you said this, and that's not the case. And I'll be like, dang. But yeah, in laws, rules, everything's protocols are constantly changing. So a lot of what I say is the case, but if it's not, just follow your facility protocol. Okay, so domestic violence, sexual assault. First, I haven't seen much sexual assault, only because where I worked at more full-time and more consistently, they automatically sent their rape victims and sexual assault victims to a rape center in Georgia. We have that here, or at least in the metro Atlanta area that I worked at. So if a patient came in, they wouldn't necessarily see us. The nurse, I think, would screen them, and then they would be sent there. So that was how they did it at my hospital over there in Georgia. But then in New York, they would be in a designated area and they would get seen. But where I worked often, they wouldn't come to our area. I think they would come to the trauma area, or they would go to the trauma area. And I don't like trauma. I don't like musculoskeletal, so I didn't like working there. But I mean, even though it wasn't necessarily a trauma case, I think they would put them there. But so I didn't really see much sexual assault either way. But domestic violence, domestic assaults, domestic disputes, whatever, I would see a lot of those. Either way, it's kind of the same as far as what to do. Sexual assault is just a little different as far as doing a rape kit and, protecting them. Both is like an integrity type thing too, and dignity. But yeah. Okay, so give me 1 second, please. Okay. So the first thing is, I'm sorry, I'm just telling my dad to be quiet. So the first thing is to follow facility protocol for whatever your facility has for rape, sexual assault victims. Domestic victims are different, but if it's like a rape, sexual assault type thing, as I said, every facility is different. Find out what they do there. Then the next thing is to take a thorough history and even greater physical. If it's like a domestic dispute, make sure you touch every area of their body. Do you have pain here? 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 Because they may sue the person, or they may file press charges, whatever it is. So make sure you do your due diligence. So do that. If police are there or whoever's involved, make sure you document that. You may want to get social work involved, and especially for sexual assault cases, make sure you provide community resources. For domestic cases too, I like to spend a little extra time with patients and find out if they have somewhere to go, if they have someone to pick them up, provide them with resources that, as I said, to the community. And don't be insensitive, of course. Have a little talk with them, make them feel comfortable, especially comfortable to come back to you if something were to happen. You don't need to ask about, their relationship with that person and if they're going to go back and not to go back and whatever, I just people are going to do what they want to do. You just have to ensure their safety and provide with resources and let them know that you're there, just be supportive. Okay, child abuse. Child abuse is pretty similar. I've only had one child abuse case, and I don't even know if it was a true child abuse. Honestly, they said the mom had like Munchausen syndrome, but I don't know what happened with that case because I couldn't access the chart. I think I forgot what happened, but with child abuse, if you suspect child abuse, the first thing I would want to say, especially with domestic disputes are not, you can inform your attendings. I haven't always with domestic violence. With sexual assault, yeah, but with domestic violence, especially, if they're grown people over the age of 18, 19, whatever, I don't really tell my attending. Of course you can, but child abuse, because it's a child, a minor, you want to always inform your attending. Well, and this depends where you work. Some places you work at, you'll have to, you'll be arm in arm, side by side, stick with your attending and tell them everything. Some places not so much. So it really depends where you work. But child abuse, make sure your attending knows about it. Okay, make sure if you suspect it, do follow proper protocols for that facility. Inform proper authorities. Do a skeletal survey. That's basically going to be the next step. The skeletal survey is a series of radiographs to look at everywhere, and they do like a number of shots in different locations to make sure. Look at old wounds, if they've had any old fractures, any old injuries, to confirm if, or to kind of support if really an abuse is going on. And you want to once again document what the parents say. I think at one point they moved the parents out the room, and the police are present. But make sure you document if the parents are going to bring them in, or their guardian. So make sure you document what they say word for word. CYA, cover yourself, guys. And then a lot of times with these child cases, the one case that I had, we had to transfer them to the children's hospital. So they don't have pediatrics at your hospital, you'll likely have to transfer them to the children's hospital. Sorry. Ooh. Okay. Sorry. DNR means do not resuscitate. That's for end of life decisions for people. You typically, as this says, I've never had to wear a PA or NP, or what we call advanced practice provider, mid-level provider. Those are all names given to us, and NPs. I've never known for us to sign a DNR or discuss that with patients. Of course, we can kind of let them know a little bit about DNR, but having like a full-on conversation, and letting them know all the different types of DNRs and all their options. I've always let the doctor do that. And the doctor, signs it and does all that with the patient or the patient's representative. So I would bring on an attending on board, because you want to make sure that the family is fully aware of what this means, what the implications are, and everything. Okay. And if the patient is not alert or oriented or able to consent, make sure a representative is present. I think the only time that they can do it through the phone or virtually or whatever it is if they're like in another state or country or whatever. But follow protocol. I would get your attending on board. But that doesn't mean that you should know about DNR and everything that's in the document and things to be aware of. It just means that you're going to be working more collaboratively with the physician, because even though they're talking to the patient about it, you're still going to have to be doing that documentation on your patient. They're going to also write documentation, but you won't be doing, that's still going to be your patient. So be mindful, be aware, be educated on all this too. And you'll learn that collaborative is really the word. We should actually be called collaborative providers. I'm just kidding, guys. No, but that's really, really what we do. We don't necessarily ask physicians for, I mean, we can ask them for their input and everything, but it's really collaborating because we still do our own stuff. We're still responsible to, submit our own charts, see the patients, interpret the labs, order medications, whatever it is. But we just tend to consult with them when we need it. So collaborative is a good word to use in your essay, guys. Okay. Psychiatric holds, very similar. The thing with these people, you're going to see kids and adults. It's very similar. This, you want to take a thorough history. There's specific questions you want to ask. You're not going to ask every patient that comes through the door if they're suicidal or homicidal. I don't ask unless they come in for psychiatric issues or unless they tell me they're depressed or whatever. You want to ask about if their SI and HI means suicidal ideations, homicidal ideations. You want to ask about their history of suicide, if they've ever done it in the past, or homicidal behavior, drug and alcohol use, life-changing events that might have precipitated these thoughts and feelings. So those are specific questions you want to ask, okay? And then they're going to do a set of labs before, to clear them medically. And you want to do a proper physical, especially a skin assessment. You want to also look at their eyes, make sure to see if their pupils are constricted or dilated. That can be signs of drug or alcohol use. If they're alert oriented or if they're obtunded, if they're not, if they're unconscious, whatever it is, that can give you a sign if, drugs or alcohol has been involved. Like I said, proper skin assessment, look for track marks for drug abuse, old scars for self-mutilation. In certain states, a PA cannot sign an involuntary hold form. Actually, in New York, I'm not sure if because the hospital I worked at was a psychiatric hospital, but we didn't have to actually, I've actually never signed a form in New York. But in Georgia and Florida, we signed the forms. So if Florida's called a Baker Act, Georgia's called a 1013. New York, I forgot what it's called. But oh, thank you guys. Somebody said get some Buckleys. I actually like Buckleys. My brother has some. I know. I'm a bad patient, guys. I really am. Don't ask me. I'm the worst patient probably sometimes. Let's not get to that. I know I need to get some medicine. I've been taking vitamin C, zinc. Zinc has made me nauseous, Tylenol, but I just kind of like things to go away on their own. Okay, in certain states, a PA cannot sign. Oh, I already said that. Yeah, in New York, I forgot what it's called, or if there's a name for involuntary hold in New York. But you want to make sure that if they require you to sign that form, you want to make sure that you are signing it for the right reason, meaning that you do believe that the patient is a danger to himself or herself and others, and why. Because the patient's going to say, why are you holding me against my will? I'm an adult. I can do what I want, blah, 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 blah. And then they can go back and sue you. They can say, oh, you held them against their will. Oh, that you kept them in the hospital, blah, blah, blah. So you have to cover yourself and write, such and such is at risk for this, patient presented with this, that, blah, blah, family is concerned for this. You have to, like I said, have great documentation and support your case for signing that sheet, because when you sign it, that's going to go on their permanent record. Y'all remember the permanent record? But that really is. That can affect them. When the patient is on an involuntary hold, that can really, really affect them. So you have to say that why you believe that they need to be placed on a hold, why they're at risk for such and such, and why they need to stay. So, and then they can always rescind it. If the doctor can, I think the doctor is the one that can. If only the doctor or the psychiatrist, or I think the therapist or something, there's only certain people that are allowed to rescind it. So you'll learn about that though. And then the psychiatrist will evaluate them, or a therapist, whoever it is in charge, will evaluate them and say whether they're going to stay or not. Okay, conflict. Okay, don't be afraid to be a tattletale. That's the number one thing. If you feel like people aren't doing what they're supposed to be doing, guys, you better snitch. This is the one time where I'm like pro snitching, pro covering, or, pro like telling on people, because it's always going to be the patient and your license, okay? If something's conflicting with that, you better get the necessary parties involved and get it situated, okay? Don't be afraid to snitch on somebody if they're not doing something right. Don't be afraid to tell, because at the end of the day, it's going to be that person's name and your name, right? If something happens to that patient, right? So if you notice something that's going on that needs to be done, you better tell the medical director, the charge nurse, whatever it is, okay? That's the one time where I'm a snitch, boy. And I'm not afraid to send somebody an email, to tell the charge nurse, to tell the doctor. Trust me, I'm gonna cover my patients and look out for my patients, okay? Okay, so as I say, always remember that it's the patient and your license. If you run into an issue with an attending, there's somebody above the attending. There's somebody above your supervising physician, and that's the director. So you're gonna meet the medical director. They're actually the ones that hire you, the ER medical directors, or if you work in the ER, they're the ones that's going to hire you. So then that's their job. They might not like getting calls at midnight or at 4 o'clock in the morning, but that's their job. So if you feel like that should be, don't go around calling people all willy-nilly. That should be your last result. But if you feel like you're so stuck and you really need to call them, call. Don't be afraid to. If that patient's life is at risk, call them. Like, for instance, one issue I had, a patient, giving you guys an example, I had a patient, an older woman. She came in with she kind of described it as, I don't know, a lot of people like to change up their stuff. They'll say like chest pain, but then they'll be like, oh, it's in my rib. Your rib's in your chest, honey. So she's older. So if a patient's older and they're saying rib pain, to me that's chest pain. I mean, that's still chest pain, but I'm going to consider it like a chest pain workup. So she said that she was basically having chest pain. And she was like 60 something or 70 something, I don't remember. But anyway, I asked her about history of a blood clot. She said she had history. So then if they have history of blood clot and they have like the risk factors and whatnot, I would do a D-dimer, did a D-dimer, came back elevated, did a CT, and it showed that she had a blood clot. And then I forgot what else the CT showed. I think it's just that she had a blood clot. So the hospitalist, I won't say the hospital. It was the hospitalist and then the residents. The residents felt that it was an old blood clot from which she had years ago. I think it was like 8 years ago. They felt like it was an old blood clot and that she can go home on medicine. Never, ever, ever in my life, and never, ever, ever will this ever happen, will I ever send a patient with a confirmed PE home, okay? I'm not going to send a patient with a pulmonary emboli home. I was taught at my PA school that those are dangerous, emergent, and people can die. If I hear that somebody can die from this, like emergently, like out of nowhere, I'm not sending nobody home and having that on my license. Because at the end of the day, and the lady didn't want to stay. She didn't really want to stay. She's like, oh, it's her old. And they were like talking to her, telling her it could be her old blood clot. No. If you're gonna stay in the hospital for a day or two, whatever, they can decide when they're gonna discharge you. But me, I'm not sending you home. And if they want to send you home, they can send you home under their document, them saying that they're okay with sending you home, and then me documented that I wanted the patient admitted. So I'm not going to have a patient go home. If they wanted to send you home, I'll admit the patient, and then they can discharge you from the ER. The hospitalists can do that. You'll go through a lot with hospitalists and this is not to bash hospitalists. A lot of times it's the residents, and this is not to bash residents either. Sometimes, but you'll go through a lot then this is just talking about conflict. So thankfully it came to the morning time to where the morning doctors came in, and it was the medical director working, and we were doing rounds, and I told him what happened, and he was like, they want to discharge a patient with the PE. Oh no, we're admitting this patient. Put the admission in. We're admitting this patient. And he had my back. And that's just me. I mean, he was a really, really good supervisor. He was an amazing medical director. I loved him. And that's like one of the reasons why I would go back to New York, because he was amazing. But he was very supportive. And if I had an issue with the hospitalist, the resident, whatever it is, he made sure that the patient was taken care of. So you guys don't ever send a patient home with a PE. No matter how comfortable you get, don't send a patient home with a PE. There's just certain things you just don't do. And I wouldn't do that. If you want to do it, fine, but I wouldn't do that. So yeah. So thankfully the medical director got that taken care of. So exactly, I've never heard of a PE. Some people can have like sometimes chronic PEs, but to have a PE and to have anticoagulant and and for it to kind of still be there years, unless years later, like maybe like a year or two, but like years later, they tripping, and to cause symptoms. Listen, I'm not a physician. I don't have like all that experience, but no, if I am uncomfortable with something, I'm not gonna do it. Okay, if you run into an issue with a nurse, a counterpart, someone in radiology, whatever it is, contact their supervisor. Okay, don't be afraid to tattletale. Like I said, don't be afraid to call people. Don't be afraid to send emails, because what did I say, guys? Tell me what I said. It's what and what. I want to hear it in the chat, or I want to read it in the chat. Tell me the rules for conflict, or what to think about when you run into a conflict, guys. Exactly. Patient and license. Exactly. If you guys put those as priority, you will do great and you will go far. When you run into conflict, exactly. Good job. Good. If you didn't learn anything today, it's to think about the patient in your license. Snitch like you in a movie, yes. Oh, I kind of said this already. All right. So make sure to talk to your supervising physician if you have any uncertainty if it comes to labs. A lot of times when I'm uncertain, it's usually due to labs or like a CT finding that's weird or something. So talk to your supervising physician, ask for help. Don't be afraid to ask the nurses for help. Nurses be knowing, they know a lot. So ask the nurses for help, especially a seasoned nurse that's been there. If you're new to a facility or traveling and new to an assignment, ask another provider or the nurses. If you think a patient needs to be admitted, like I said, admit them. Don't even bother going back and forth with some people. You do what you need to do. And especially if the doctor agrees that the patient needs to be admitted, admit them. Unsure about anything imaging related, call radiology department, or ask to speak with the radiologist. If you need to confirm that a CT is what it says, call the radiologist and utilize your resources. I love UpToDate and Hippocrates. It's like all that I use, UpToDate, Hippocrates. I know there's more resources, but I love UpToDate and Hippocrates. So it's the same concept that nurses have. Actually, nurses' patient assignments is a little different. They're assigned less patient. Well, I'm not even gonna say less. It really depends on the facility. Some states have a limit on how many patients at a time a nurse can have, but yeah, they'll be assigned to a certain area in the ER, and yeah. But as far as the number of patients, it varies. Alrighty, guys, I think I'm done. As I always say, know what's common, know zebras, know what can kill you. Zebras are like zebras. You probably never see them ever in your life. But when you see it, you gotta know something about it for that light bulb to pop. And know what can kill your patient, like a PE. And don't have residents come after me. I love my residents too, guys, okay? Okay, any questions, guys? I hope this was helpful. I hope it was good learning. Let me know. This is my social media once again. Thank you, guys. I hope I feel better too. Alrighty, guys. Good night. Have a good night, everyone.